Good afternoon. And today I'm so honored to introduce very special guest, hero of my book, and very passionate cardiologist, Dr. David Fieno. Good afternoon, David.
Hi, Maria. How are you?
I'm so happy to see you here on my podcast because I want to educate my audience about such a close connection. What you see so close in your with your through your eyes in a surgical suite, connection between sleep and heart, and how sleep can be very deadly. And very deadly not only for the person who have a cardiac problem, but also for family members. So this one, I'm dressed in red, everything around it in red because I want to illuminate heart problems. And some people think they are really far from them, but the stories what I put in my book, they were not too far from me. And that's actually those tragic episodes changed my life trajectory. So again, thank you very much to my audience. If you have trouble sleeping or sleep next to the snoring partner, it's not just a noise. It may be body crying for help. And you have to pay attention not only to that disturbance, but also to cardiac health. And if you're a medical professional who, just like us, are so passionate trying to put a little piece puzzles of sleep apnea together to bring better health to our patients, also this episode is for you, because now we're not going to talk about only improving patient life and make everybody happy and healthy like I really like to talk about. Now we're going to talk about saving patients' life. And I suggest you to follow me on my book journey because you're going to know Dr. Fieno from the pages of my book in a lot of chapters. So my first question to you, Dr. Fieno, and I want to talk about you. Dr. Fieno, not just a cardiologist and medical background, he has a PhD and it's engineering or scientific background, and now he applied all his vast knowledge in the science to his practical cardiology. Based on these principles, he really saved people's life. And you can find more information about Dr. Fieno and his full bio underneath this interview, but he has a master degree in biomedical engineering and doctor of philosophy in biomedical engineering. And only after he got a PhD degree, he went to medical school and became surgical cardiologist.
I'm a glutton for punishment, Maria. So that's all there is to
it. But of course, I would like you, in a short version, give our audience the introduction how your life turned to that, because I think it helped people to connect with you better. But then I want to ask you those practical questions, what we discussed and I discussed in my book.
Sure, Maria. So the first thing I think we both share a passion for is helping the patient that's in front of us. And let's just say it out loud. Sleep apnea is extraordinarily common. Dental problems are extraordinarily common, and cardiac problems are extraordinarily common. And I think for a long time, people have known that there's a connection between the health of your teeth and the health of your heart, but only recently have brilliant clinicians really gotten out there and identified the link between sleep apnea and your heart. And the truth is, we're still figuring it all out. I think with your passion and with also your willingness to spread the word, that I think the subspecialists like yourself, like Dr. Allison Cole, and like me, I think we're all actually treating the same disease. And the ideal scenario is where we treat it before our patients succumb to a cardiac arrest, to a respiratory failure. Like you said, snoring and having difficulty with sleep is just the beginning of the story. So I share your passion, and I'm excited to work with you on this program, and then hopefully work with you and Allison in the future.
Absolutely. So I want to ask the question, what really bothered me for many years. I'm treating sleep apnea for last 15 years. So tell me, I see patient medical history, and some time ago it was just the words. Now it's become life, friends, and patient stories. So tell me, how does untreated sleep apnea contribute to atrial fibrillation and other arrhythmias, and why cardiologists should pay attention to sleep apnea more?
So it's a great question. So the question you're asking is how might untreated sleep apnea contribute to problems with the heart, specifically atrial fibrillation? And then the second thing you're getting at is what can we do about it? So two great questions. So the first thing is sleep apnea, or apnea in general, means that a person stops breathing. I was diagnosed with sleep apnea 15 years ago, and someone near and dear to my heart once measured, I stopped breathing for 2.5 minutes in my sleep. And just try to hold your breath for a minute sometime. It's very difficult. 2.5 minutes, that's getting to the point where things are life-threatening. And the mechanism is obvious, but we'll go ahead and say it. The lungs exchange carbon dioxide for oxygen. Carbon dioxide builds up as a byproduct of your cellular metabolism. If you don't do that exchange because you stop breathing, carbon dioxide builds up, you become acidotic, and that causes things like fluctuations in blood pressure. It causes the heart to have to work harder to circulate deoxygenated blood. And then finally, your tissues, such as the brain, the heart itself, the muscles, are robbed of oxygen. And it's exactly the same as if you have a clogged artery, which is what I do. When an artery gets clogged, the area gets robbed of oxygen and other blood. So that leads to why sleep apnea, particularly untreated or undertreated sleep apnea, may cause cardiac problems. The depriving tissues of oxygen are going to first affect the organs that are the most metabolically active. And the three organ systems that most people talk about are the brain, the heart, and the kidneys. Those are the ones that are the most metabolically active. So with those three, usually 15 minutes without oxygen, your body can tolerate. More than 15 minutes, people know that cell death actually occurs. So when we're talking about sleep apnea, we're in that in-between phase where the tissues have not undergone cell death or necrosis, but they're becoming injured. And in that becoming injured phase, when sodium and potassium levels change, calcium levels change, pH changes, that's when arrhythmias can occur. And more than 10 years ago, it was suggested that particularly in men, as they get older, they tend to have sleep apnea. They get big necks. Their airway occludes when they lay back. And when this happens, they get more and more supraventricular arrhythmias. They get arrhythmias occurring from the top part of the heart. And atrial fibrillation, or an irregular heartbeat, is kind of the prototypical one. The scary thing about this one is cardiologists know that 30% of AFib goes undiagnosed. People don't know they have it. They might know they snore, and that's about it. And then the last thing that's relevant to what you said, a lot of people get a sleep study. They get prescribed an orthotic, something that goes on their face to help them breathe. But unfortunately, the thing doesn't work, and they never circle back to say, what do I need to do to change this? So Maria, I think you're spot on. And I think as we can increase awareness of this stuff, we can start to help people treat this condition.
Thank you. That was such a great answer. But I want to ask you the question, what I raised so much in my book, and what, I just mentioned, I think trajectory of my life is sudden cardiac death in sleep. It can happen in sleep or right when patient actually get up. That's how it happened in my life. So it might occur at night, might occur in the morning. What we know about sleep disorder breathing and sudden cardiac death, because that's like a most devastated thing what can happen when death happens without any warning, in front of your eyes and what to do about that. It like can be traumatic, not just for that person, but for so many people around it. It can irreparably ruin so many lives.
So you bring up a great point. So not only is sleep apnea associated with various cardiac problems, so I mentioned a few of them, atrial fibrillation, hypertension, but there are others: pulmonary hypertension, left ventricular hypertrophy, congestive heart failure. All those things are associated with sleep apnea, particularly untreated or undertreated sleep apnea. But then there's one more thing that is really close to my own personal situation and also my practice, and that is the association between sleep apnea and sudden cardiac death. So what is sudden cardiac death? Well, we know that every year about 500,000 people in the United States alone die suddenly, and they die without warning. What's really interesting is we've known this for 30 years, and fewer than 3% of these people ever get to the hospital. The majority of these people are just dead. So what can we do to prevent sudden cardiac death? Well, nobody knows the answer. People have tried genetic analysis. People have tried screening, imaging. They get their physical with their doctor. They get their evaluations by the subspecialists like you and I. And so far, nothing has worked. The only thing we've been able to do is identify risk factors for sudden cardiac death. And the belief is that if we can do things to ameliorate or reduce these risk factors, we can, in fact, reduce sudden cardiac death. So going back to the beginning of our interview, if a person stops breathing for a minute and a half, 2 minutes, 3 minutes, eventually their heart is going to run out of oxygenated blood. The first thing that happens when that happens is very often there's a reentrant circuit. And rather than the heart conducting electricity from the top down, this reentrant circuit overtakes the entire cardiac muscle. And if it does that from the top, that's called atrial fibrillation. If it does that from the bottom, that's called ventricular fibrillation. Atrial fibrillation is a survivable event, and 9 times out of 10, you take in a big deep breath or you Valsalva, and the AFib goes away. But ventricular fibrillation is very often 99.9% of the time not survivable. The only thing you can do is have a defibrillator at home, recognize the ventricular fibrillation, and literally shock the patient out of ventricular fibrillation. So what people need to be aware of is that not only is sleep apnea annoying and make it difficult for the patient to sleep and their family members to sleep, not only is it having effects on their cardiac system, their pulmonary system, their psychiatric system, but it is actually one of those risk factors for unexplained sudden cardiac death. So if you're overweight, body mass index over 25, if you snore loudly, or if you have daytime sleepiness, you fall asleep while you're driving, you feel terrible, out of energy all day long, those are all subtle signs of untreated or undertreated sleep apnea. So time to see Dr. Sokolina, time to see Dr. Cole, time to see someone who specializes in sleep apnea, can get you a sleep study either at home or in the office or both, and then find out if you're a candidate for therapy. Those therapies are what we need to do, and those might be the only thing that would reduce that burden of sudden death. I think that we're still sorting out the exact reason people die with sleep apnea, but it's undoubtedly related to that deprivation of oxygen.
And I would like to ask you, one of the treatment of sleep apnea, what Dr. Cole supports 100%, and I support as well, is the CPAP machine. But this particular remedy or treatment strategy contraindicated the patient with the severe heart failures. How to navigate the paradox in that practice, and why is that? Like, what to do about that?
So heart failure is extraordinarily common. As a heart failure cardiologist myself, I think it's underdiagnosed in our society. And CPAP, or continuous positive airway pressure, or BiPAP, which is bilevel positive airway pressure, are the two of the gold standard treatments for obstructive sleep apnea and central sleep apnea, but they're two of the gold standards treatments. The problem is both things are relatively, not absolutely, relatively contraindicated in patients who have heart failure, which a whole bunch of people have heart failure. And the reason why they're relatively contraindicated is the positive pressure increases the loading on the heart and can cause things like pulmonary edema, swelling, and can cause an already failing heart to have to work even harder. Maria, we prescribe them anyway, which brings up the next point that orthotics like CPAP are not the only therapy for sleep apnea. Weight loss, we now know, is effective, whether sheer willpower or with one of our newer agents. We know it's very effective for treatment of sleep apnea. In the old days, with people who could not tolerate their CPAP, they would get a prophylactic tracheostomy and hook up to that at night so they could breathe. The last thing is there are, believe it or not, advanced pacemakers, devices that we implant and either connect to the carotid body, the recurrent laryngeal nerve, or to the heart nerves itself, the phrenic nerve. And those devices may be emerging therapies for sleep apnea. So the bottom line is that our therapies are there. They are imperfect, to say the least, and a collaborative approach among the specialists like you, myself, pulmonary, general medicine, everything. It's really important so we keep our patients on the right track. And the final thing I'll mention, since sleep apnea causes a lot of cardiac problems, atrial fibrillation, left ventricular hypertrophy, right ventricular hypertrophy, pulmonary hypertension, everything, AFib, we ought to think about monitoring those patients even more carefully than we presently do. In other words, a lot of times visit with the cardiologist once a year, that's enough. But if we know that they're at higher risk, we should have a lower threshold to see and test these patients more frequently to try to get an idea, are they moving in the right direction?
My question to you, kind of general. I'm wondering, you talk about a lot of cardiac, failures or cardiac problem undiagnosed. We know from statistics what 87% of sleep apnea is undiagnosed. And the rates actually in the United States, we talked before the interview in statistics, 70% of female, 24% of male, they, do have a sleep apnea. But in Germany, it's 50%. In Japan, it's 50%. What's so different about diagnostic or preventative medicine here in the United States? We know a lot of German descent live here in the United States and a lot of Japanese descent live here in the United States. If we have that miraculous approach, what we have such a low rate of sleep apnea, which I don't think so, because we're actually kingdom of fast food, or we just do something so different, or maybe not every cardiologist ordered the sleep study, patient visit him. So give me that your view on this problem.
You're definitely asking the right question. So the question is, why in the U.S. do we seem to see a higher incidence of sleep apnea diagnosed in females than males? And then secondarily, in other countries, why is that ratio closer to half and half? And what might account for the differences among the sexes about the finding of sleep apnea? And the answer is that nobody knows. There are at least three possibilities, and that is a female statistically is about 3 times more likely to seek help than a male. Men will have a heart attack for a week and terrible symptoms before they get checked out. Women tend to get a little more ahead of things, and whether that's because they are more likely to see their general doctor, their OB-GYN for their routine exams, or whether between the sexes, whether there's just culturally more inclined to seek medical care than men are, nobody knows. But that's one hypothesis. A second hypothesis is that, in fact, sleep apnea is very similarly occurring between the two sexes, but men are more likely to refuse the evaluation for sleep apnea because they know they're going to get a CPAP, they know they snore, they say they feel fine, and they say they don't care if it has problems, I feel fine. And then the last possibility, and this is something that I've only come to understand recently, they have these studies of the posterior pharynx where there are these pads that are full of adipose tissue. They refer to it as visceral adiposity. And it may be that the rates at which that expands is different in a female versus a male patient. In any case, I think the point that you made initially is the most true, which is that overall, probably only 1 in 5 people that are out there that have sleep apnea actually get the formal diagnosis with a sleep study. And it's probably fewer than that ever get successfully and appropriately treated.
That's very sad. That's very sad. But my last question, I always see, let's call it arrhythmia. So resting rate of the heart should be, according to the book, below 90. But I see, I would say, 50% of the patients who come to me for sleep apnea treatment, the resting rate above 90, it can be 120, or it can be even higher. At which point cardiologists start worried about resting heart rate being so high.
Keep in mind that by the time your heart rate is abnormal, probably damage is being done, which is why I mentioned that if you have sleep apnea or if you're likely to have sleep apnea, they need to be evaluated more frequent intervals, at shorter intervals with the cardiologist, because once it becomes closer to end stage, much of the organ damage is irreversible. So, answer your question about heart rate. In general, the normal heart rate that we quote for people with a normal sinus rhythm is between 60 and 100, patients 18 and above. Now, I see a lot of kids. Kids can have higher resting heart rates, and that's normal. I also see a lot of athletes. Athletes can routinely have a resting heart rate between 40 and 60. I saw a rower the other day whose resting heart rate was 35, perfectly normal. Then another thing about the absolute number, the atrial fibrillation, there was a study about 10 years ago called the RACE-2 trial. And we used to think that AFib, their heart rate needed to be from 60 to 100. Turns out it doesn't. The heart rate for atrial fibrillation patients, if they have persistent atrial fibrillation, is usually between 40 and 120. So they allow lower and higher heart rates for patients with atrial fibrillation. And the bottom line is people have a tendency to go to the grocery store, buy a blood pressure cuff, and then try to interpret their resting heartbeat. So what you really need there is you need that visit with somebody who's cardiovascularly trained. And they can tell you, is that resting heart rate normal or abnormal? For example, my rowing patient, in context, that was perfectly normal. Day before yesterday, I put a pacemaker in somebody. Their resting heart rate was in the 30s, but they were passing out. So they obviously needed a pacer. So it's all the number and the clinical context. And it's fine if you check your heart rate, but don't bother trying to interpret it. That's where you get into trouble. The last thing, in patients with undertreated sleep apnea, they have 2 phases with their heart rate. The first one is they tend to have an accelerated heart rate when the sleep apnea is becoming uncontrolled, when it's becoming cardiovascularly significant, cardiovascularly deadly, if you want to think about it that way. And then what's interesting is in the later stages, their heart rate goes the other direction, and they actually have a lot of vagal tone from the 10th cranial nerve coming out of their skull. And they tend to get profound low heart rates, pauses of 5 to 10 seconds. Either one can be an indicator that their sleep apnea is becoming harmful to their cardiovascular health. And both the sleep apnea and the underlying cardiac stuff needs to be treated. Usually weight loss is extremely helpful for these patients. And today, at least 50% of the patients that I see, I try to personally help them lose weight, and it helps a myriad of syndromes.
Thank you very much. I really appreciate your opinion, and I'm looking forward to introduce you in a book, and people would know you better, but they can find a lot of your social media presence on on internet and listen to your interview, and I find them very insightful. So you can find information about Dr. Fieno underneath this interview, and check your heart with cardiologist. So thank you very much. Really appreciate that.
Thank you, Maria. It's been a pleasure.